Hello, everyone. Good morning, good afternoon, and good evening, wherever you may be, wherever you are. I am Dr. Arthur Polela, anesthetist practicing at Levi Monawasa Hospital here in Lusaka, where it is exactly 6 minutes past 7 p.m. I welcome you all to this webinar, which is sponsored by the African Society of Regional Anesthesia in conjunction with the Society of Anesthesia in Zambia. So I welcome you all. So today we're discussing regional anesthesia for rib fracture. As you are aware, rib fracture, a major cause of morbidity and mortality in a lot of our trauma patients here in Africa, and I presume in the global West as well. So today, my job is basically to moderate this session. As I've mentioned already, I'm a regional anesthesia enthusiast and an ambassador for the African Society of Regional Anesthesia. I also serve as an executive member of our association here in Zambia. So today, presenting today's topic is Jonathan Womack, who is a consultant anesthetist working in the NHS in, as far as I know, in Newcastle, where he works at the Royal Victoria Infirmary Hospital. And I believe it houses a major trauma center in that region. And he's also involved in teaching, as well as in cadaveric studies and a lot of research. Jonathan is also a board member of the Regional Anesthesia UK, and we're delighted to have Jonathan today. Today's discussion will be divided in 3 parts. We'll start first with a theory presentation, followed quickly by a live scanning session. And to top it up, we'll have interactive discussion with Jonathan. I'm very much looking forward to today's topic. Very interesting, let's see what Jonathan has for us today. Jonathan, over to you.
Thank you for inviting me, Mo. So I'm Jonathan Womack. I'm a consultant anaesthetist in Newcastle in the UK, and I'm going to talk today about regional anesthesia for rib fractures. So this is a bit of a theory before we do some scanning and then some questions. So the first thing to think about is rib fractures themselves. So how do you injure your ribs? Well, often it's associated with a high impact injury. So many of the rib fractures that I see are patients that have been in road traffic accidents, or motorbikes, or high speed car crashes, falling off things, often high impact injuries. And those sorts of injuries often come with other injuries as well. So sometimes the rib fractures aren't the biggest problems that the patient's got. The other patients that we see rib fractures in are frail patients. So sometimes they've fractured the ribs in quite innocuous ways. So a bit like a hip fracture is a fracture of frailty, and a pelvic fracture is, so can rib fractures be. So sometimes these injuries are sustained falling from standing height or relatively low energy impacts. The next thing is that they're really painful. So bones are sore when they're broken, when they move. So periosteum rubbing against periosteum. And the problem with ribs is that ribs are needed to move because we have to breathe. So rib fractures are particularly painful, and it's dynamic pain with each breath. The other thing about rib fractures is that they are they're painful for quite a number of days. So in fact, even months. So patients that sustain a rib fracture will be uncomfortable for a really, really long time. Fortunately for us, or not fortunately for the patient, the severe pain generally lasts around about 5 days. It often starts moderately badly, but gets worse over the first 3 days and then starts to get a bit better. And by day 5, patients can often start to manage with oral medication. That's obviously very variable. So some patients have lots of rib fractures that aren't painful. Some patients have 1 or 2 rib fractures that are really painful. Some factors make the rib fractures more painful than others. So particularly flail segments or multiple fractures, fractures that are in continuity and small cracks on the bone often aren't moving as much, so are less painful. But generally, they're pretty painful, and they're painful because they move. Now, because of this, patients with rib fracture pain will avoid taking deep breaths, and they'll avoid coughing. So that means that they don't clear secretions, that they get atelectasis, and then that can lead to respiratory failure. Also, opiates, for example, if used as an analgesic, will also impair this ability to cough and potentially lead to respiratory failure as well. So as a result, rib fractures have got a pretty high, surprisingly high mortality. Certainly at our institution, when we looked a few years ago, the predicted mortality of hip fracture patients was around about 8 to 10% for 30 days. Rib fracture patients are actually higher mortality, were a higher mortality, so it was 12 to 15% in 30 days. And that's confounded by the fact that generally hip fractures are sustained in old comorbid patients, and rib fractures are sustained in a variety of patients. So some of them are old and comorbid, and some of them are young and fit. So I would suggest that a hip fracture and rib fractures in the same patient, the rib fractures would probably have the higher mortality. We don't tend to think of it like that, but it really is quite a significant injury. So why should you offer regional anaesthesia for patients with rib fractures? Well, there's actually a lot of downsides to doing it in terms of, well, not downsides, but there's lots of things that stop us from being able to offer this. So obviously, often anaesthetists are giving anesthetics in a list, elective surgery or emergency surgery, and we don't have time. We're putting blocks in for patients with rib fractures, extra work, which we don't have time to do. So certainly that's the case at my hospital. We've had to fight for some extra time to do this, and that can be a real hassle. The next thing is that sometimes these patients are looked after by other specialities, so you may not know that they're happening, or that they've fractured the ribs, and they may not be aware that they need pain relief. It's slightly easier if you're on critical care and you do critical care and you're looking after patients with rib fractures, but not every patient with rib fractures that's uncomfortable needs to go to critical care. So I think there's plenty of reasons to be doing this. So one of the first is, particularly in the UK, we have some standards that suggest that we should be doing it. So this is the British Association of the British Orthopaedic Association, and they suggest that all patients with blunt chest wall trauma should be reviewed. We should have an analgesic protocol, and that includes the use of neuraxial and regional blocks, if appropriate, and that should be available. There is some evidence of improved outcome with the use of regional anaesthesia in patients with rib fractures. So there's a couple of papers here. So one is from our centre. So this is we looked at all the patients that had ultrasound guided paravertebral catheters, and we saw that there was certainly a trend towards lower mortality in the rib fracture group, and that would be it was just on the edge of statistical significance when you take into other confounders, but would have been quite a significant reduction in mortality. So looking at something like a 7% to a 3% mortality reduction. So quite significant, as in clinically significant, but statistically just about or on the edge of significance. And this fits with a larger multi-center study from the US, where they looked at epidural placement and blunt thoracic trauma. And there was some evidence of reduced mortality in patients that were having an epidural. And certainly much of the evidence for rib fracture pain relief is from epidurals, mainly because they've been around for the longest. One of the problems with the paper the paper about epidurals was that they didn't account for selection bias. So if you, or time bias. So essentially, if you survive to having an epidural, then that is obviously makes you more likely to survive, because some patients will die early on. So if you're a polytrauma and you die of your transected aorta, you never survive to have an epidural. So it does require you to survive 12 hours. I account for that in our study, and that may be one of the reasons that it wasn't quite statistically significant. And really, the final reason, or the most important reason, is satisfaction. So particularly patient satisfaction. So pain is an unpleasant experience, and if you're in pain with each breath, and that's delaying your mobilization and recovery, then it's definitely a worthwhile thing to do, in my opinion. And I think acute pain relief is one of the most fundamental roles of a doctor, and it's also very professionally satisfying as well as a doctor. The ability to deliver high standard of pain relief to a patient. So, who? Now, this is two questions. The first is who should get a block, and the second is who should do the block. So there's a bit of a debate in the UK about who should do blocks for rib fractures. I think this will really depend on the setup of wherever you work, and it's different between each hospital in the UK, and it will also be really significantly different, I'm sure, in different countries, really depending on who runs critical care, who runs the trauma wards, how many doctors there are in your hospital, whether it's a small hospital or a university hospital. So one way to do it is to make anaesthetists do it, or ask anaesthetists to do it. And I think the majority of us today obviously will be anaesthetists or anesthesiologists, if you prefer the American terminology. Obviously, regional anesthesia is a branch of anesthesia, so it makes most sense that anaesthetists have the skill set to deliver blocks for rib fracture patients. So I think a gold standard service would be someone that's doing regional anaesthetic blocks regularly, and I think certainly in the UK, most of the time that's an anaesthetist. But might be different elsewhere in the world. Another group of doctors that could do it are emergency doctors, emergency medicine. One of the disadvantages that they have, the advantage is that they see all the patients with rib fractures. A disadvantage, and also in the UK, they have lots of transferable ultrasound skills. A disadvantage is that they don't have necessarily the volume of experience of regional anesthesia, and certainly putting a catheter in is potentially time consuming. Certainly in the UK, lots of emergency medicine is about triaging and stabilizing patients. So time consuming procedures are probably not something that they're interested in doing. However, single shot injections might be the way forward in an emergency department to get your patient comfortable for having a scan. That's certainly one way. And another way might be for trauma surgeons or thoracic surgeons, whoever look after the patients with rib fractures to deliver them. Disadvantage of this is that they don't have the transferable skills that the anaesthetists do. And the final group might be someone like critical care, particularly if a number of these patients are on a critical care unit. Again, it depends on whether these are anaesthetic critical care doctors, how many blocks they do. Certainly, there's lots of different ways that people could do it. And allied health professionals, so specialist nurses, nurse anaesthetists can I'm sure that in some healthcare settings, we don't have very many in the UK, but elsewhere, they may well be able to deliver these blocks. So there's certainly lots of people who could do the blocks. And I think it really depends on the demands of the service as to who you pick to do the blocks. Patients-wise, that's a bit more clear, I think. So we're always offering an intervention on a risk versus benefit. So every block, every clinical intervention that we do entails some risk, and so that risk has to be worth the benefit. So the patients who are most at risk of complications and death are patients who are over 65, which is actually surprisingly young, I think, patients with more than 3 rib fractures, and also respiratory disease. There are a number of scoring systems for identifying patients that will benefit from a block. So one score is called a rib score. So this is actually a radiographical score. So what you would do is you'd look at the location, number of ribs, whether there's flail segments or not, and decide who to offer a block to. There's a similar rib fracture score, which looks at numbers and patient factors, age, etc., to decide who are the high-risk patients. We use a scoring system called the PIC score. So that is a composite score of pain, inspiration, capacity, and cough. So pain is graded as mild, moderate, severe, or non-existent. Inspiratory capacity is graded as below expected or below the alert level. So the alert level is a level by which we know that patients will have a difficulty coughing, and that's based on ideal body weight and their expected inspiratory capacity. And then the final domain is cough, so whether the patient can cough or not. And you can use the number that PIC score generates to determine which patients will benefit from a block. And then you can use scoring systems. So in the UK, we've got something called a PS17. So this is, or it may even have been updated now. It's been quiet over COVID, but that's quite long, a few years ago now. That's a probability of surviving major trauma. So TARN is the Trauma and Audit Research Network for the UK. And they basically plug all the numbers of patients that had similar injuries, and it gives you an idea of that individual patient's probability of surviving the injuries. So you can use scoring systems like that. We have a slightly more simple scoring system that we use at our hospital, which is essentially, does the patient have severe pain? And what I would class as severe pain is pain that is not managed with oral medication. So we tend to go for a block rather than a PCA first. Other hospitals would give IV morphine before they go for a block. And I think that's really, there's no right or wrong answer there. I think we're very comfortable with doing chest wall blocks. We have the provision to provide any patient who wants it a chest wall block. So we choose that over a morphine intravenous infusion, mainly because of the respiratory suppressant effects of morphine, and also the fact that a morphine infusion potentially ties you down to a drip stand and to a machine, whereas with a block, you can have your drug delivered in an elastomeric pump, which is essentially a balloon that deflates over time, so the patient can mobilize without being tied to a drip stand. So severe pain. So you could either have severe pain, which is not managed with oral medication, or severe pain, which is not managed with IV opiate, if you felt that IV opiate was worth pursuing in patients with rib fractures. The other thing that we should consider, and this is again UK centric, because that's where I work and that's what I know, but certainly we're expected to discuss with every patient the risks and benefits of the treatments, and we'll come on to that a little bit later, and the alternatives, including no treatment. So really, what are the alternatives to a block for patients with rib fractures? Well, the first is not to treat the pain at all, and I would suggest that that is unsatisfactory from a patient-centric perspective, although it may be realistic if you simply don't have the facilities to treat the pain. The next is opioids, so morphine and the like. Again, these may not be available in the healthcare setting you're working in. Certainly, I was in Sierra Leone a couple of years ago doing some hand surgery, and opiates were very, very difficult to get hold of in the hospital setting. We didn't have IV morphine at all. Maybe the opiates aren't available depending on where you are. And then the third one is fixation. So there is a bit of a trend at some centres in the UK and in the US to fix rib fractures in the same way that any other bones are fixed. Our surgeons were early adopters and early rejectors of this. So they decided that the majority of rib fractures probably don't need fixing. It's not necessarily that straightforward an operation. And they felt that it was most beneficial when there are significant ventilatory issues from the rib fractures. So really significant flail segments, posterior rib fractures, essentially ventilatory failure secondary to abnormal or disrupted rib cage. However, some other centres, so in the UK, will fix ribs on the basis that it's painful. And there is some merit in that. Bones that are fixed become less uncomfortable. But certainly the evidence for fixation purely for pain relief is not there. And I suspect that that certainly elsewhere in the world, the surgical expertise to fix ribs and the widespread availability of it is probably not there. Which looks pretty strong for a block. If no treatment is not really an option, opiates may or may not be an option, and fixation isn't an option, I would suggest that regional anaesthesia is probably the best type of treatment for rib fracture pain. So which block to pick? Well, this was from a couple of years ago in Anaesthesia journal. A review article, and essentially they decided that there were too many choices and there's not enough evidence either way. But let's have a think about what we could do. So epidural. So epidural is old. This is a picture from my textbook of regional anaesthesia in 1945. So epidural, or peridural as they're calling it here, block existed in 1945 and was already an established technique. They've got a slightly unusual way of performing it with a sort of almost hanging drop style technique there, but it certainly existed. So the advantage of epidurals is really they're not an unknown quantity. So we know the most about how epidurals work. So we have the most evidence of effectiveness, but also we know really what the complication rate is. We know, for example, that there's a 1 in 100,000 chance of a epidural abscess or death, or whatever the complication may be. But we also know that they work. So there's two major downsides to epidurals. The first is complications. So in general, the complications of an epidural are rare. So in a patient that's fully anticoagulated, epidural hematoma, which is the most feared complication of an epidural is about 1 in 100. So that's a fully anticoagulated patient. So in a normal patient, in an unanticoagulated patient, it's much less common than that. However, when the complications do happen, they can be absolutely catastrophic. So a paralyzed patient at the end of it is not what you want. And if there's an alternative which reduces the chance of this that works, then it's definitely worth considering something else. I think the biggest problem with epidurals, certainly in my setting, is that they're really high maintenance. So most of our wards can no longer manage a patient with an epidural infusion because they need higher levels of nursing care than we're able to deliver there. So it means that a patient with an epidural has to go to critical care or a high or a ward environment with high level of observation. And it's just not practical to offer this to every single patient with rib fractures. I think there is definitely still a place for epidurals in patients with rib fractures, and that's when you've got a really significant number of rib fractures. So most of the novel techniques only block one side of the chest. So if you've got extensive bilateral rib fractures, the epidural is probably still the only technique that's going to cover them all. So if we're going to think about the other techniques that we can use for rib fractures, we need to go back to the anatomy. So remember that the thorax is supplied by the thoracic spinal nerves, and we've got these here on the left-hand side of the screen. So the epidural space is here in the middle. They come out, they form a posterior rami, which supplies skin over the back, and they form an anterior rami, which supplies most of the structures within the chest wall. So this anterior rami gives off two branches. So an anterior branch of the thoracic nerve and a lateral branch. And you can see on the torso here, the area that's supplied by the anterior branch is the skin here, from nipple or mid-clavicular line inwards. And the lateral branch supplies an extensive area of skin from mid-clavicular line at the front to mid-clavicular line at the back. In addition to that, the nerves of the thoracic nerves supply most of the muscular structures and the bony structures of the chest. But that excludes the shoulder girdle muscles. So they are the pec muscles, the serratus muscle, and the latissimus dorsi muscle on the back. So those essentially move the shoulder. So they're brachial plexus branches. So they will not be innervated by these nerves. Thankfully, the ribs are innervated by these nerves. So what we essentially need to do is block multi-level, probably, because usually we're blocking rib fractures for patients with multiple rib fractures because they're the most uncomfortable. A multi-level thoracic spinal nerve block. So the first way to do that is with a paravertebral block. So that is an injection in the little starred area that we have here on the screen. And a single level paravertebral block gets a consistent unilateral multi-level spread. So this is the expected spread after a T4 injection. So we're getting a spread from around about T2 to T6. Now, the exact level of spread is variable in different patients, but certainly if you have 4 rib fractures or 5 rib fractures, or maybe even 6, one single paravertebral will cover that. If you have more than that, you may need more than one. My preference is for using the transverse oblique technique. So we've got a video on it in a bit. So the probe is placed here between ribs, with the ultrasound showing the transverse process, which is this structure here, the pleura, paravertebral space here, and the intercostal muscles. So when I do the block, I advance the needle from lateral to medial into the paravertebral space here, open it up with some local anesthetic, and thread a catheter in. The next option is to do something called an erector spinae block. So that is an injection on the transverse process here. So it's represented by the blue and the green star. So the reason I've put a blue and a green star is that the two patterns of spread noted from cadaveric and from volunteer studies. So sometimes, well, every single time you get extensive spread up and down in the erector spinae plane, but that's not especially useful for rib fracture analgesia unless you've got very posterior ribs. So rib fractures just here next to where they articulate with the transverse process. In that case, you'll get direct periosteal spread. Now, the two ways that the erector spinae might then work, so that explains this block on the back. So the block of the posterior rami, and that's quite extensive. So that's a really wide level of spread. One mechanism might be that it spreads along above the rib in the serratus plane, and it moves laterally. And that's one of the reasons why sometimes in some of the studies of the nipple to sternum, and that's because rather than numbing the whole nerve, it's just numbing the lateral branch. So it might be that if you inject in the erector spinae plane, local anesthetic spreads along in this plane here, essentially giving local anesthetic to the periosteum of the rib. Another alternative mechanism is that actually some of it spreads through to the paravertebral space. So we do know that there are holes in the ligaments here between the different spinal levels, and so it is possible that local anesthetic spreads through, and you get essentially a paravertebral block through spread to the paravertebral space. And this is how it would explain the second pattern, which is represented in blue, which is something that looks like a paravertebral block. So spread all the way along, but you note that this is probably slightly less spread to the paravertebral space than you get with a paravertebral, which makes sense. And it might be that actually the block in rib fracture patients works in a combination of ways. So some of it spreads along above the rib in the serratus plane. Some of it spreads into the fracture site itself, and some of it spreads to the paravertebral space. So there might be multiple mechanisms, which explains why sometimes you don't get the same cutaneous block, but you get analgesia for rib fractures. And this paper was in Anaesthesia on the same week that our study of paravertebrals in rib fractures was released. And this was a group from the US, from I think Pennsylvania, maybe. And they were looking, or maybe Baltimore. And Ki Jin Chin contributed as well from Canada. And they demonstrated a improvement in respiratory dynamics and pain relief with erector spinae block. Now, this was a cohort study rather than a randomized control study, but certainly the change in respiratory dynamics was probably what I would expect from our paravertebral blocks when we've measured inspiratory capacity. It was pretty similar. So I suspect there is something in an erector spinae plane block. The evidence at the moment is not great, is not high quality, but there's certainly evidence that the erector spinae plane block probably works for rib fractures. The other evidence is that it's extremely popular. So it's really taken off in the UK particularly. We don't do it at our centre because we already could perform paravertebral blocks. But in lots of other places where they didn't offer a rib fracture service, they're now routinely performing erector spinae plane block. It was found by accident, and I just think I put these both up just to demonstrate that lack of parasternal block. So this is the first on the left is the first description of erectospinal plane block, and some parasternal sparing is noted in both of these patients. And on the right was from a relatively recent study in Rapham, looking at erectospinae and thoracic paravertebral block for rib fracture pain. And you note that there's parasternal sparing in the ESP compared to the here parasternal 0.3 versus 3.1. So that's the number of anesthetized dermatomes in comparison. So there's a relative parasternal sparing in the ESP compared to all of the other dermatomes. And that's a statistically significant one. We'll again go on to how to perform an erectospinal block in a bit. The ultrasound is generally placed in the sagittal paramedian plane, and essentially the place to inject is in this plane. Transverse process. Transverse process is here, and the erectospinal plane is this plane between transverse processes. Now, a third option is the serratus plane block. That is above or below the serratus muscle. Below the serratus muscle is rib or intercostal muscles. And this is another potential space. So if you inject a large volume here, you get spread upwards and downwards, and you get a block of the lateral branches of the intercostal nerves. So I would suggest that for rib fracture pain, injection below the muscle makes most anatomical sense, because otherwise local anesthetic would have to diffuse through the muscle. And we did a cadaveric study that was again published in Anaesthesia, which suggested that that probably wasn't the case, that if you inject above the muscle, the local anesthetic or injectate stays there. And if you inject below the muscle, that's where the local anesthetic stays as well. So I think this is probably useful for lateral rib fractures. You're essentially injecting on top of the ribs and numbing the periosteum. It's quite an easy block to do. So you essentially put the ultrasound probe in the mid-clavicular line, which is where these nerves are, sorry, the mid-axillary line, which is where these nerves are coming out. And you find ribs and you inject on the rib. And you open up this plane underneath the muscle that's going over the ribs. The other option is to inject above the muscle, but like I said before, I'm not entirely sure how that works for rib fractures, or it may be that the serratus muscle is involved with coughing. So if you immobilize some of the serratus muscle, you cause a motor block of that muscle, that part of the chest doesn't move as much as the other parts, which enables the patient to take a deeper breath. But I think below the muscle makes most sense in my head. It's generally considered to be more technically challenging because your needle's going deeper. But actually, if your endpoint is hitting a rib with a needle, it's not too bad. It's almost exactly the same as the erectospinae block. So remember that we're always considering risk and therapeutic benefit here. So how do these blocks compare? So the first thing is, what's the evidence for therapeutic benefit? Well, epidural is generally considered to be the gold standard, and paravertebral comes quite close, I think. So there is some RCT evidence for pain relief from paravertebral for unilateral rib fractures, to say that it's equivalent to an epidural. And also there's some evidence of improved outcome similar to epidural. The evidence that epidural makes a strong outcome difference is poor as well. As mentioned earlier, for ESP block, there is some evidence of equivalent inspiratory capacity to what you'd expect from paravertebral, but this is from cohort study. It's a reasonable size, but it's not the same grade of evidence. And for serratus plane block, it's really limited to case reports, which is weak evidence, really. So if you wanted to use good evidence base for your block, you'd pick epidural or paravertebral, and maybe erectospinae if you were feeling generous. The risks, well, we've discussed earlier that the risks of epidural are rare, but potentially very, very serious. Paravertebral blocks, pneumothorax is a risk. The risk of a significant pneumothorax is probably overstated in a paravertebral block, especially if you're using ultrasound and you're confident where your needle tip is. There's a large study from Massachusetts General where they looked at the incidence of complications from paravertebral block single shots, and pneumothorax is really, well, they didn't see it. So that was in 1,500 paravertebrals. So paravertebral can be delivered safely in expert hands with an ultrasound. And the other thing is that remember that these patients have rib fractures. So pneumothorax is a significant risk from the rib fractures themselves. So I think it's also worth remembering that the risk is of not providing analgesia. So even though epidurals have rare but serious risks, rib fractures themselves are pretty dangerous. So an untreated pain from a rib fracture, we've said before, has quite a significant mortality. Even if these are risky blocks, epidural and paravertebral, the same risk as having rib fractures in the first place. ESP and serratus, the risks are difficult to quantify. Certainly, people have caused pneumothorax from ESP and serratus plain block already, but you would imagine that they're less risky because the needle goes is less deep, potentially less risk of an uncompressible hematoma. But these are all theoretical. So on the basis that they're more superficial and you're passing fewer structures, they're probably less risky than a paravertebral block. But this is probably, we don't have strong evidence that they're definitely less risky. And then finally, they all have limitations. So the first is epidurals. So hypotension is potentially a significant problem with a thoracic epidural infusion, especially in a patient with multiple injuries. And the second problem that we've got is length of infusion. So remember that I said that usually 5 days of extreme pain or high pain from rib fractures. Generally, we want to be thinking about removing epidurals after 3 days to reduce the risk of infection. So we always have to have a plan for what to do at the end of the epidural infusion. Now, paravertebral blocks and other peripheral nerve blocks, we tend to run for longer because the risk of infection is less significant. So the advantage of paravertebral ESP and serratus is that we potentially can run the infusion for longer. The big negative of a paravertebral block is that they're technically challenging, and I don't think it's an ultrasound-guided nerve block that you should do if you're not experienced at ultrasound-guided regional anesthesia. But erector spinae probably is a block that you could do as a moderate beginner. And same with serratus plain block. They're less technically challenging. The big limitation is that at the moment we don't have very strong evidence of how good the pain relief is, and how good the pain relief is in comparison to a paravertebral block or epidural. And the final thought is that the pain lasts for days. So we're going to need to extend the pain relief, and usually that's with a catheter, or the alternative would be to perform multiple injections. And we're also going to have to follow up these catheters. So we have an acute pain service that goes to see these patients every day, or it could be, the doctors that put them in. But they generally do need a bit of fiddling to get right. So whether it's changing the infusion rate, or giving an extra bolus, or troubleshooting, it's definitely an active process. It's not just a case that you put a single shot injection in and then leave the patient to their own devices. This needs active follow-up. There's two ways really to give an infusion, or to run medicine down a catheter. So the first is with an infusion. So that's what we do at my hospital, because we can't give it a programmed intermittent bolus with our pumps. Programmed intermittent bolus is when, rather than a continuous infusion, the machine delivers a bolus of local anesthetic over a set period of, every couple of hours. There is some evidence that intermittent boluses are better, so particularly for epidurals. Now we tend to use programmed intermittent bolus and indeed patient-controlled boluses. So I suspect that in the future that will be the way that we deliver local anesthetic for rib fractures, with a mixture of programmed intermittent bolus and patient-delivered PCA feature. The advantage of boluses is that you get a bigger spread because you get more turbulent flow, which means that you get a better block for however much local you're giving. And with a patient-controlled button, that means that they can give themselves the right amount of local anesthetic. You generally get less toxicity with the boluses because you generally use less local than you would for an infusion as well. Although the big concern with the bolus is that the bolus goes in all at once and the catheter is in a blood vessel. I always check when I put a catheter, and I always check with a local anesthetic down the catheter to make sure that the catheter is not intravascular. The third option, if you don't have any pumps, is to do an intermittent bolus. So this would involve a healthcare professional going to the patient and injecting down the catheter. It's kind of the same as intermittent injections, but you leave the catheter in so the patient doesn't have to get stabbed each time. The only thing I'd say about this is you just have to be very careful that either that you use NR-fit connectors so that you can't give local anesthetic into a drip by accident, or you have a stringent safety mechanisms to stop whoever's doing the bolus from injecting into a drip, because that would obviously be disastrous to give a bolus of local anesthetic intravenously. And then the next question is which drugs to run. So we run either levobupivacaine. So for our paravertebrals, we tend to use 8 mils an hour of 0.25 levobupivacaine. I think often for erector spinae blocks, people tend to use a higher volume, but 0.125, and often with an intermittent bolus. So 20 mils every couple of hours, something like that. Ropivacaine 0.2%. 0.2% is also an alternative. We don't tend to use it, but it has a better safety profile. The problem with ropivacaine compared to 0.25% for paravertebrals is you generally need to run it at a higher rate to get the analgesia. But I'm sure it works well for erector spinae as well. Good. So that's regional anesthesia for rib fractures. In summary, I think regional anesthesia is the best that we can offer. It's better than opiates. It's better than not treating the pain. But it is challenging. It's challenging to do the blocks, but it's also challenging to manage them afterwards. So you need to run them as an infusion. You need to follow these patients up. And also, we've got so many unanswered questions about which is the best block. Are erector spinae and serratus playing the same as paravertebral block? Are they less good? Are they safer? Are they not less safe? We just don't know. And the final thing is that whatever service you offer will be dependent on the resources that you have available. So it probably looks very different to what my service looks like. And that would be whether you're based in a different hospital in the UK or elsewhere, or again in Africa. There's such a wide variety of healthcare setups that it's worth thinking about what you can realistically offer, what skill sets you have available, and how you can make the best for the patients with what you have. And that's it. So hopefully we'll be doing a bit of scanning now, and then some questions. Thank you very much.
Thank you very much, Jonathan. Such a great presentation, very informative, and I hope our attendees enjoyed it as much as I did. Of note is that you're already addressing some of the questions that I had prior to this presentation. So that's very, very nice. So we move on straight to the live scanning session. And again, Jonathan will take us through this session as well. And yeah, so over to you, Jonathan.
Now, so I'm just going to give Curly a bit of wipe for his tummy, and we'll get you sat up facing Ash that way. And Ash can. So, moving on to the back, we're going to have a quick look and scan and see the anatomy of the erector spinae and paravertebral space. So, lots of jelly, always. You never have too much jelly, and the patient can take more jelly than the pro. The best way to orientate yourself, so here I'm going to have the, to the left of the screen is going to be cephalad. So when we put the ultrasound probe on, you can immediately see just parasternally in the parasagittal view, you can immediately see some tube-shaped structures. So they are either going to be transverse processes or ribs, and we can confirm either way. So if I scan medially, you see that those, all of a sudden, those slightly curved structures have become more superior and flatter. And if I move laterally, they're curved. So that laterally is a rib, and if we move in medially, it's articulating with the transverse process, and now we're on transverse process. Now, if we move more medially, we will find some point facet, which would be here somewhere. Difficult to see on this with this ultrasound setting, so I won't persevere. Now, when we're on the transverse process, which is here, we can see three muscle layers. The erector spinae muscles, immediately obvious. So you can often see three muscle layers. So trapezius, rhomboid, and maybe a bit low for rhomboid. So here we are, that's better. So trapezius, rhomboid, and the erector spinae muscles. The rhomboid finishes at around about T5. So that's, you can see it tapering off here. So we can tell that that's the T5 level. To be honest, as long as you're identifying the muscle that's over the transverse processes, it doesn't matter too much. So this would be a nice image to do roughly a T5, T4 erector spinae block. And we'll point out on the screen the layer that you need to inject. Now we can count up by going right up to the top, and then looking for the first rib. So that's first rib, just the left of the screen, second rib, third rib, fourth rib, fifth. So there, that's rhomboid tapering off. So where we were counting was correct before. Now you can also do it much lower. So depending on the level that you want to go, you can do it anywhere along in the thorax. So you can do in or lumbar. So here a transverse process is much lower down. So to orientate yourself at the bottom, the best thing to do is count ribs. So we've got one rib there, so that must be, and that's a small rib that we can't see that well. There's no ribs below, so that must be the 12th rib, 11th rib, 10th rib. Fine. Paravertebral space. Yeah. So my preferred technique for doing the paravertebral is to swing the ultrasound probe around. So we have the rib in profile. So if we can get a nice rib in profile here. So we've counted our space. So this is probably it's probably T4 just from where we looked earlier. So if I'm with the rib in profile, I'm just going to slide off it, but aiming to keep the transverse process in view still. So with this image, we have a transverse process on the right of the screen, and then pleura at the bottom, and the intercostal muscles articulating with the transverse process. And you can see there's a little triangular wedge just to the left of the transverse process, which is a bit darker, and that's the paravertebral space. You can also do an erector spinae block in this orientation. So you'd come from lateral to medial and inject on top of the transverse process. An MTP block would be somewhere between the transverse process and the pleura, and a paravertebral space would be in that dark triangle at the bottom. So this is my preferred technique for a paravertebral, and it's a nice way when you're starting to learn to move from erector spinae to paravertebral. The reason that I like this orientation is you have a nice flat needle angle, and a very, very clear, you can see the needle the whole time, and it's very, very clear. Yeah, and that's the paravertebral space.
Paravertebral, Jonathan, because it was much better for you.
Okay, so moving from the transverse process view for the erector spinae, my preferred, I would count the level, and my preferred technique for a paravertebral is to do transverse oblique. So what I'm going to aim to do is get the rib in profile, so we can see here the bright white line is the rib articulating with the transverse process. And if I do keep the transverse process in view, you can see on the left, on the right of the screen, transverse process, bright white line with dark below it. No longer a rib, so the bright white line at the bottom of the picture is the pleura that you can see sliding. And above that, you've got intercostal muscles and a dark little triangular wedge, which is the paravertebral space. You can also do a erector spinae from this position as well. So if you come in lateral to medial here with a very flat needle angle and inject on the top of the transverse process, that'd be an erector spinae block. You could do an MTP block, which is halfway between the transverse process and the pleura, and then a slight angulation downwards into the paravertebral space. So when you do a paravertebral, you get the nice dropping of the pleura as a clear endpoint. I prefer this orientation to do a paravertebral block because you have a nice flat needle angle. You can see it very clearly, and you can it's very easy to visualize the needle in the paravertebral space. The danger is that you're pointing at the intervertebral foramen, so you don't want to advance the needle beyond the transverse process at all.
Right.
All right, that was lovely from Jonathan. Quite clear, and you think as if it's so simple, and encourages me actually to do these blocks more and more. Thanks again, Jonathan. So we'll start with our third session of our webinar today, and we'll be discussing what has been presented by Jonathan. I encourage participants to feel free to type down your questions in the chat room, and Jonathan will hopefully try and address some of them. So I prepared a few questions for you, Jonathan.
Great.
If you let me. Initially, I thought of asking a few things about the anatomy and the physiology, but you explained them quite well. So my biggest concern with doing these paravertebral blocks is, first of all, choosing the right probe for the right patient. Do you sometimes, I noticed in the video that you use the linear probe. My last attempt at doing the same with the linear probe seemed a bit difficult because the patient was a bit bulky. So would you, in that situation, for example, choose a curvilinear probe, or is it a technique issue?
Yeah, no, I have a low threshold for using a curvilinear probe. The model in the video was really slim, so it was only a couple of centimeters deep. But if there's anyone who's not slim, i.e., the same build as Curly, who modeled there, I just go straight for the curvilinear probe. I've tried to use the linear probe for deep blocks, and the difficulty with the curvilinear probe, I think, is needle visualization is more tricky. it's less forgiving about where you put your needle in your plane, but your anatomical image is much better. So I think if you're struggling to see the paravertebral space, get the curvilinear probe out. Definitely, I agree with you there.
Okay, I'm only just starting out doing these blocks, and the first thing I noticed is that the feel as you going through the different layers is quite different when you're doing a femoral block, a popliteal block. Would you recommend a different type of needle? Is it a more echogenic needle that's easier to see, or what would you recommend?
What are you using at the minute, Arthur?
We use the Pajenk needles. They are 80 millimeter needles, and sometimes I face difficulties visualizing the needle.
So we tend to use the Sonoplex, Pionk Sonoplex needles. So we've got 50 and 100 millimeter ones. For catheters, we've got Pionk TUI catheter kits, and the TUI needles are a bit bigger. So I think they're 18 gauge maybe, or they're certainly, maybe not 18 actually, maybe they're 20 gauge. They're certainly a bit bigger than the normal block needles, and they're quite visible. So one of my colleagues has wondered about using, for the deep paravertebral blocks, it can be difficult to see one of the smaller one of the smaller block needles. So he wonders about using a TUI needle, essentially an echogenic TUI needle. So you can get those. I like the Sonoplex needles. I think you can see them generally. So I do use those. I prefer to use a 50 millimeter needle if I can. The 100 millimeter needles are a bit bendy. So I think I try and use a 50 millimeter, but you can't always use one. Sometimes you need 100 millimeter.
Awesome. What about what other patient factors do you consider when choosing your needles or your technique?
So one thing to consider is whether you have them sat up or on the side, particularly for patients with rib fractures. And that is very much down to the patient. So I'm quite used to putting the blocks in on the side because we do it post-induction for breast surgery. So that's how we tend to do our blocks in the breast cases, and we roll the patient. So I'm quite happy doing it with a patient in the lateral position. And it's quite interesting. Some patients with rib fractures can easily sit up, and some patients find it really uncomfortable to sit up. And some people can roll on their bad side up. Some patients can't actually breathe very well with the bad side up. So I just leave it to the patient. I think it's probably, I don't know if Mo's in this, I know he's around, he may text as an answer. I think it's probably easier to do an erector spinae with the patient sat up, I would imagine. But again, you can probably do it in either position. And the easiest thing to do, especially with rib fractures, is get the patient in a comfortable position so they're comfortable. Another problem with rib fracture patients is surgical emphysema. So if you've got extensive surgical emphysema, you can't see very much at all. You won't be able to see into the paravertebral space. You can sometimes see some transverse processes. So that's the main reason that I've done landmark paravertebral blocks recently, and sometimes also just a landmark erector spinae as well. You know, you can find a transverse process or a rib. You can find some bone and inject on it. You know that you're going to get some relief. The block is never quite as good as well, I don't think. I think surgical emphysema itself is quite uncomfortable. So it is challenging with patients with surgical emphysema. Any other factors? Obese. I mean, I don't know what sort of patients you get with rib fractures, but we get a mixture of frail elderly patients who are often you could use whatever probe you wanted. You could probably feel the transverse process. And then lots of the patients who have traumatic rib fractures are sort of motorcyclists who've they're generally quite stocky and big, and are tensing. They're uncomfortable. They're the most difficult ones. They can be really challenging. That can be very deep.
Awesome. I wonder, does the site of the rib fracture influence which choice of block you pick, or do you have a favorite block for all rib fractures?
Yeah, so I tend to do paravertebral blocks. Unless it's very extensive, 15 rib fractures or something like that, you would probably only really be able to use a thoracic epidural. But they're really unusual. It's very unusual to get that, a number of rib fractures that you can't treat with a paravertebral or a ESP or etc. People talk about this. So serratus plane, there's a bit of a debate about whether it's good for lateral and anterior rib fractures and whether ESP is better for posterior rib fractures. I don't think that, I don't have the experience of either to say with any certainty. I think that probably makes sense. When we've done, what an advantage of serratus is, let's say a patient with a spinal fracture as well, you can't roll. So you put the serratus in on the side. My experience of it is always that the bolus works quite well, and that the infusion never seems to be very effective. So you just have to keep putting extra boluses down it. I don't know. Do you have an experience of lateral or posterior rib fractures in different blocks, or not a strong opinion?
We don't have that much experience in either. So yeah.
I'd say that probably the best place to start is probably an erector spinae. That's probably the sort of beginner paravertebral, or the more straightforward paravertebral.
I was going to ask the same, because the paravertebral block seems to be a bit more technical, and from what I've read, they encourage beginners to start with an ESP.
Definitely. So we do paravertebral blocks because we did paravertebral blocks before ESP was invented. So it's difficult to justify going to do something that's less proven when you already offer something that you do safely and effectively. But I think if you're starting a service, you may as well go for the thing that is achievable, because you're going to have to train up several people to do it. So it has to be achievable. And I think ESP probably is to find anyone that can do a femoral block can probably do an ESP with an ultrasound. And you could probably, landmark technique's not described, but you can probably do a landmark technique if you hit a transverse process and then inject local. And I think that the reality is that serratus plane is quite similar to ESP in terms of the technical aspect of it. So you can probably do you can probably do a serratus block if you can do an ESP. It's just that you put the probe in the midline rather than in the back. Yeah. So I think I'd start with ESP. That's probably the one that seems to be the one that's popular across the UK. So we're unusual that we don't do ESP. We do paravertebral. So we're unusual. So ESP probably is the one. So that's where I'd start. Okay.
We do quite a bit of breast surgery and thoracotomies. Any advice? I understand these can be used for these procedures as well. So what do you think, any modification, anything that would be done differently in the event you're doing it for a breast surgery or any other chest wall surgery?
Yeah, so thoracotomy, we can start with that. The incision is obviously lateral, isn't it? Usually, so it's usually through the lateral cutaneous branches. So I think probably, and there is a reasonable amount of evidence that I've seen for serratus, erector spinae, both of those for thoracotomy incision, and you could also do a paravertebral as well. The only thoracotomies we do at my hospital are the esophagectomies. So they do it thoracoscopically now, and the surgeons place a surgically sited paravertebral catheter in. So I don't actually anaesthetize patients for esophagectomies. If I was doing a thoracotomy, I'd put a paravertebral in, but equally, I think you could probably do either a erector spinae or a serratus plane block. Both would probably work. There's a question about intercostal nerve blocks. I heard a talk recently from some of the guys in Belgium, and they were saying, so I think the problem with intercostal nerve blocks for rib fractures is getting spread upwards and downwards. So, and actually, the difference between a paravertebral and a proximal intercostal nerve block is they're probably near enough the same thing, but a more lateral intercostal nerve block, you'd have to do multiple injections. So the advantage of a ESP or paravertebral is that you don't have to do multiple injections and you can leave a catheter in. However, the guys in Belgium were doing surgically sited intercostal nerve blocks and catheters for their thoracotomies. So you can there's probably loads of things that you can do for thoracotomy. For a breast surgery, just remember that the anterior branches aren't blocked definitely by serratus plane or PEC 2 block, because they're basically the same thing. That's your lateral branches, and maybe not by an ESP. So if I was doing either an ESP or a serratus or a PEC block, I would do some anterior infiltration along the side of the sternum to get those anterior branches. And the other thing is that the pec muscles are innervated by the lateral medial pectoral nerves. So if I'm doing a deep operation or an operation where they're putting an expander or something underneath the muscle, then putting a block for the lateral medial pectoral nerves is worth doing as well. For my breast surgery, I do 2-level paravertebral block and plus or minus a pec block. But, as long as you cover the nerves, it works.
You mentioned the PEC 1, PEC 2, and some will say they're just a variant of the serratus anterior block. Do you ever perform those separately, or have you stuck to the serratus anterior?
Yeah, so I don't tend to do the PEC 2 block. Someone asked in the questions about PEC 2 block for rib fractures. So it's a bit confusing. They've changed all the words recently, haven't they? All the terminology recently. So it's not really. So PEC 2, the PEC 2 block is very, very similar to a serratus plane block. It's probably in the same plane, or a superficial serratus plane block. For breast surgery, I found that the surgeons don't like it because the local anesthetic is in the plane where all the lymph nodes are. So they prefer either a deep serratus plane block or a paravertebral block. For rib fractures, I think it makes much more sense for me to put local underneath the muscle so that it's next to the ribs. It doesn't make much sense to put it above it. So I don't think there's probably a place for PEC 2 block in rib fractures. But then again, some people think that that the superior serratus plane block or the superficial serratus plane block works for rib fractures. I've never tried them for rib fractures, so I don't know. Because it's more superficial, it's safer. I'm not sure how it works for rib fracture pain because you're not blocking the nerves to the ribs, but it may work. It may be that the muscle that you essentially numb the muscle so the patient can cough easier. I'm not sure, or there's some spread there. PEC 1 between the two muscles is a lateral and medial pectoral nerve block. So I think that's probably worth doing for some deep breast surgery. I don't think it contributes to rib fracture pain.
To take you back a little bit, on your technique, do you ever use the out of plane technique? Others have argued that the needle takes a shorter course than in plane, so it's maybe more comfortable for the patient. What do you think about that?
So I don't tend to do out of plane technique. We had a bit of a debate about it when I went to Romania relatively recently, and so I think a lot of European, so continental European, I am European, but generally British anaesthetists don't tend to do out of plane approach very often, and I think the continental Europeans do tend to. We had a bit of a debate about it. I think you can do it safely. I think a lot of people don't do it properly, as in a lot of, certainly the people that I've seen in the UK do it, it's basically an old landmark technique, but they look for spread with the ultrasound. They don't really know where the tip of the needle is. I think there are definitely people who do it properly, who visualize the tip of the needle the whole time. It's not usually that uncomfortable. Especially if you're using one of the block needles rather than a 2E needle. I think the other thing particularly with the paravertebral, now an erector spinae, I can see that there's potentially some rationale for doing an out of plane needle. I think for the erector spinae, you are aiming directly at the pleura when you do an out of plane approach, whereas when you're doing the in-plane approach, you're aiming kind of away from the pleura, because the pleura are going down like that, although you are aiming at the intervertebral foramen. So there's another argument, which is it's easier to thread a catheter in if you use out of plane, because you're to the side of the spine, and you kind of threading the catheter up like that, as opposed to threading the catheter like that. It's tricky. So I don't know. I think whatever you're comfortable with, I prefer to use in plane, and I can't say that the discomfort is that much of an issue. I think that's an academic argument that isn't. Yeah.
All right. In our setting, it may be a bit difficult to have what do you call it, the intermittent boluses, and to thread the catheter. For several reasons. It would need training the nurses on the ward on how to use some of these equipment. Is there a role for a single shot, either paravertebral block? Is it beneficial, or does it always have to have, or can you even repeat the paravertebral block once it has worn off? Would you recommend that, or what would you advise?
So I think you realistically, if you do a single shot, it will wear off. It's unlikely to cover the duration of severe pain. However, I suppose it might. But I think it's always worth remembering that the pain relief will wear off. So there's a couple of ways around it. One is to bring the patient back and do a second block. The single shot block, probably, I don't know how long it lasts for. It's difficult to work, it's very difficult to tell how long a single shot block lasts for. Probably 12 hours, maybe something like that. So I think you've probably got two options. One is to do repeat injections, which is obviously resource dependent on this being someone that's able to do it. The other thing that you can do is do you have catheters at all? Because if you had an epidural style catheter.
They are available. We have a few epidurals.
So I suppose what you could do is you could bring the patient back to theatre to top them up with, an anaesthetist or someone who's familiar with it, and do the repeat injections that way, rather than training the nurses to do the injections. But again, that's resource dependent, but I suppose it's less resource dependent than repeat. If at least there's an anaesthetist available who knows how to give local anaesthetic down a catheter, then that's more achievable than someone who knows how to do an ESP or a paravertebral, maybe. It's tricky. I don't know exactly. It may be that repeat injections scheduled for X time are the way forward as well. I'm not sure.
Okay.
Someone said about Exparel. Now, I don't know what that is. That liposomal bupivacaine? That might be.
Say that again. Sorry, I missed that.
Someone in the chat has said about Exparel. Yeah, liposomal bupivacaine. Yeah. So we never use trade names in the UK. So we can. So it's always a bit of a mystery what the drugs are. We don't have liposomal bupivacaine. The reps wanted to come and speak to us about it for spinal surgery a few months ago. I mean, that would work. Presumably, I've got no experience of it whatsoever. My understanding is that it takes a while for the analgesia to kick in, and you can't give another dose of a different local. So you can't give, because it displaces the bupivacaine from the liposomes. But it may work. We don't have it in the UK, so I'm not sure. If you give IV Dex, there was another question about additives.
There was one about adjuvant. Yeah.
Yeah. So I don't tend to use additives because it's not standard practice. But you could give IV Dex at the time when you give it, or Dex in the block, and that would extend your single shot. But it's realistically going to extend it for hours rather than so you maybe you get 24 hours out of the block, which might be enough to do another block the next day. In terms of other additives, the other thing I've used in a paravertebral is clonidine very, very occasionally. I've added it to the infusion, and that seems to have made it a bit more effective. I've not tried anything else. Don't routinely add fentanyl or anything like that.
Sorry, take you a little bit back. You said sometimes use a toy needle. That sounds like quite a big needle. Do you infiltrate with lidocaine before you do that?
Yeah, we always infiltrate with lidocaine before we do the block, actually. Okay. And for our auxiliary blocks, they put xylocaine on the skin, not xylocaine, Emla cream on the skin as well. I have to say, I tend to infiltrate with local. I think it'd be really interesting to your perspective on it, but a lot of patients in the UK are expecting a general anaesthetic, especially for an operation. Patients with rib fracture are more accepting of an injection. And so I think little steps to get them on side make a big difference to the outcome. So if the auxiliary block isn't too uncomfortable, they're expecting it to be really sore, and it's not. They're quite happy. So I always put local anaesthetic in and Emla cream. I do whatever I can to make sure that the block, whether it's needed or not, is another thing. But it just means that they think that I care, which I do. But you make an effort to make them as comfortable as possible. So I put local anaesthetic in. With the smaller block needles, it's maybe not so important. Although, and the other thing with the TUIs is they come with a little skin cut, like a little scalpel to cut the skin. I tend to do that because they're such big needles that especially with someone with rib fractures, if you push on their ribs to get it through the skin, then it's uncomfortable.
It looks like we're running out of time. We've got plenty of questions. Hope you've got enough time for me.
Yeah, of course. I'm not in a rush.
All right. I'd like to ask, do you have any special considerations when you're doing these blocks in children? And I'm sure you have to take into account the dosage and probably the volume as well. What's your experience with these blocks in children?
So interestingly, the blocks are quite easy in children. So as in, it's all superficial. So you can use a linear probe often. Sometimes you can't. We have some quite big children as well. So we have a pediatric anaesthesia department, and we've done paravertebrals in quite small children with ultrasound. Obviously, the smaller that they get, the smaller the space, so it does become technically challenging. But I've done it in, and the other thing is, we usually do blocks in children asleep.
Yeah.
That's, I think, pretty standard. I'm quite relaxed about doing blocks after induction of general anaesthesia. I know that some people don't like to do it, but particularly for kids, I think there's evidence that it's actually safer to do it when they're asleep. And we have occasionally done blocks for children with rib fractures, but they've normally been ventilated on intensive care, and then we put the block in and wake them up. I don't remember ever doing one on an awake child on a ward, and I think that children don't tend to break several ribs at once, and if they do, it's usually a really significant injury. For other surgery, obviously they'll be having a general anaesthetic as well, and they work. Blocks in kids are great. It's more superficial, it's easy, and obviously you adjust the dose accordingly.
Thank you. We're in the process of trying to set up an established regional anesthesia service at our center here, as well as our main hospital at University Teaching Hospital. Do you have any advice that you can give as we endeavor to do this? I noticed, for example, you seem to imply that you're doing oil blocks, either in theater or a specified area. What would you recommend that some of these blocks can be done on the ward in the event that you have adequate monitoring?
Yeah. So depends where you. So we have a number of block areas. So we tend to do the pain relieving blocks. So we do things for hip fracture, rib fractures, etc. We tend to do those either in the emergency department in resus, so they have monitors and ultrasounds in resus, or we do them on a ward. In our block area, and it's mostly because we have the monitors there. It's as quick for the porters to go and get a patient to our block area than it is for us to take all the equipment to the ward. And you've got all the stuff, I suppose if you had a trauma ward where you're doing blocks all the time, it might be worth having a block trolley with all the equipment that you'd need. The risk is that if you leave a block trolley somewhere, other doctors take stuff off it and they don't stock it, they don't replace it, and they'll start trying to do stuff. They'll steal the ultrasound machine, etc. So we tend to keep our stuff with us. We don't have space. We wanted to have a procedure room on the trauma ward to be able to go down and do these things, but we don't have space. Space is a premium, and I think if you're putting a catheter in, it's better to do it somewhere that's a bit cleaner than a ward bed. If you go to a block area, you've got a bit more space. Yeah. So I think probably a block area is good. And then we do it in the same place where we do the blocks for hand surgery, the blocks for the trauma list. It's basically an area of recovery, theatre recovery, that we've got an ultrasound machine in.
Awesome. Let's see. Almost forgot. We, as you know, the number of physician anesthetists here is not so great. Would you recommend that some of these procedures can be taught to either we have BSc anesthetists that are trained, we've got nurses, basically non-physician anesthetists. Would you recommend that some of these may be taught to some of those so that they can be delivered in a safe manner?
Yeah, I mean, as long as there's in the UK, we've got mostly physician anesthetists. There are some PAAs who sound a bit like, so they're called physicians associates in anaesthesia. So they're from a variety of backgrounds. Some have got science degrees, some are recovery anaesthetic nurses or critical care nurses that have done other exams. We don't have any of those at our hospital. And that's all I would say most places don't have them, but there are a few around. I know that in some places like Birmingham, the physician's assistants do blocks. In other places, they don't. And I think it really just depends on whether they've been appropriately trained. For hip fractures, there's a statement from across society statement that said that anyone who's appropriately trained can do a block for a hip fracture. So whether that's a appropriately trained ED doctor, anesthetic nurse, paramedic, that as long as you have a robust training program, that you make sure that the quality is maintained and you know how to manage toxicity. So I think really it just depends on what facilities you have available. So I mean, if your anesthetic nurses or nurse anaesthetists are giving anesthetics, that's probably more dangerous than putting a block in. And if they can learn the technical skills, which I'm sure they can, some of our anesthetic nurses learn vascular access, so midline service for difficult vascular access. So, you know, the technical proficiencies there, provided that you have a good training program, there's no reason, I don't think. And managing local anesthetic toxicity, etc., having a protocol for that.
Okay. Do you teach your blocks to all your registrars in anesthesia program, or at what level do they begin to start being exposed to regional anesthesia?
Yeah, so we teach. Historically, not everyone had to do some, but not everyone had to be. But so anesthesia training is 7 years in the UK. So you're expected to do some up until your 5th year of anesthesia, and then you can choose whether you do any more or not. From now onwards, from this year onwards, everyone's expected to be able to do the REUK Plan A blocks. Well, not quite. They're expected to do an upper limb block, a lower limb block, and a chest wall block. But actually, the Plan A blocks would cover it. But that's the first time. So I would say, so we did, in our region in the Northeast, we did a survey of our trainees, and about 3/4 can do a lower limb block, half can do an upper limb block, and about 1/4 can do a chest wall block. And then all the Plan A blocks from our UK, 12% of the registrars in our hospital could do that, which is a bit poor considering how much we do in our hospital. I was quite surprised at that low number. So in my department, we've got about 80 anaesthetists, and I would say we've got 15 or so people who can do pretty much every regional anesthetic.
Awesome. Thanks very much. I'm looking at that. I asked that because we're trying to find a way in which you can sustainably teach regional anesthesia block. We're privileged to have someone trained formally in regional anesthesia and acute pain. So we're trying to see where we can go with that. Okay, with that said, maybe, okay, you were about to say something?
I was going to say it's tricky. The training's really tricky. I think running regular courses. So if you have lots of hands-on ultrasound scanning workshops, that's a good way for people to get comfortable with an ultrasound probe. Teach the basics. So teach how to get your needle, you know, how to hold the probe and the needle properly. And I think that those things together means that when they get to a patient, that they're ready to properly do a block, and they know what they're about to do. One of the problems I think with regional anesthesia is at the start, it's challenging. So when you're first starting, the blocks take a while. The surgeons lose confidence because the blocks don't work. So what you really need to do is hit the ground running, don't you? So I know so many places where, especially at the start, where people try to introduce regional anesthesia services, and you need a bit of time to get good at it. and that's the challenge, is convincing everyone else that, once it's established, people are quick and slick. It's the same as everything. You get better the more that you do.
Yeah. Awesome. Thanks very much, Jonathan. Maybe we can look at some of the questions on the chat and on the question session.
So I think we answered a lot of them. Someone asked about, where were we looking? Blind blocks, resource limited areas with no ultrasound. I think that probably, so you can do all of the blocks you can do with the landmark technique. Epidural, obviously, I wouldn't do a thoracic epidural with ultrasound, probably. Paravertebral is an old technique that you can do with loss of resistance, or you can do the walking off a transverse process and going a centimetre or half a centimetre to a centimetre. Erector spinae, I think, probably is feasible with the landmark technique, because you just have to hit a transverse process, and it's the same as a serratus plane block, just hit a rib. So I think the advantage of these blocks is that they're plane blocks. You just have to inject local anaesthetic. They're forgiving, So I think a lot of the first paravertebrals I did with an ultrasound were, we had an old S nerve with a linear probe only. So I think I was doing lots of MTP and erector spinae plane blocks, realistically. It's only now that I've got good machines that I can, see the big difference. So I think it's probably worth doing. And, as long as you have a mechanism to make sure that they're working, go and see the patients afterwards, I think you can do these blocks with the blind technique. And I suppose it just depends on your experience, whether you're experienced at paravertebrals with a landmark technique, or you just want to hit a transverse process.
All right. So I think that's it. I don't think there's any other question that hasn't been attended to. So any last words for you, Jonathan?
So Ahmed Hassan said, what has parasternal spare, ESP or paravertebral? Yeah, so the parasternal sparing appears to be the ESP block, or at least less consistent. So paravertebral block, you definitely get parasternal block, definitely. You can put your hand here, cold spray on either side, and it's definitely different. It's ESP has got some parasternal sparing.
Okay, thanks. Any last words, encouragement to someone like me who's, or anything you'd like to say, Jonathan?
So I think good luck. I think it's definitely worth doing, and everywhere in the world needs pioneers that start it. I've been to Romania recently. They had a guy who was very, very enthusiastic, and now certainly his city, all the trainees can do regional anaesthesia, and it's spreading to other parts of Romania, and it's the same everywhere. In the northeast, where I work, there's one or two guys that started regional anaesthesia, and now most hospitals have got a regional anaesthesia department. But that's not the same across the UK. There are some hospitals where just no one does any regional, so everywhere needs someone that is going to start it and drive it. And once you do, it takes off, because the surgeons like it, the patients like it, and your colleagues will. So a lot of the resistance comes from anaesthetists, other anaesthetists who can't do blocks, and eventually they'll appreciate it.
Awesome. Once again, as we come to an end to this program, I'd like once again to thank you, Jonathan, for taking time to prepare this presentation for us. I'd like to thank the attendees various members of the African Society of Regional Anesthesia, Muhammad, who's been quite essential in making these things work. Yeah, it's been a good experience, and I can feel that we're going to new heights. Yeah, so with that, I'd like to thank you all once again and officially close this meeting. Thanks once again.
Thank you very much for inviting me. Absolute pleasure.
One more thing, I heard from a bit that you might be in Rwanda, so I'm looking forward to meeting you and others like you, and see how we can chat and help each other grow.
Yeah, brilliant. We'll be in Rwanda in September, so I'll see you then.
Awesome. Thanks very much, Jonathan, and thanks
No worries.
everyone. Cheers.
See you later.
Later.